Good morning, everyone. So I'll be talking on multimodal imaging in uveitis, and there might be little repetition or overlap with some of the cases which has already been discussed previously. So does MMI actually makes a difference in uveitis? Yes, we have the evidence here. This is one of the largest studies in uveitis with more than 6,000 patients over a period of 30 years, and it was found that the percentage of patients with unidentified cause of uveitis decreased from 50% or 55% in the 90s to almost 25% by 2020. And this huge difference is due to many factors, of which an important is multimodal imaging involving OCT, ICGA, SDOCT, wide field imaging, which has really made a difference, EDI OCT, which has given more depth, UBM, etc. So here I'll go take you through some of our cases where the imaging really made a difference. So this is a 36-year-old man who came with a decrease in vision. Fundus just showed some vague RP changes, and the person who saw did a fields which showed central scotoma, and he was referred as retrobulbar neuritis. But the autofluorescence showed a classical hyperautofluorescent lesion with ellipsoid zone loss and outer retinal nodularity. So we suspected outer retinitis. He was positive for TPHA and VDRL. So this is a case of acute syphilitic posterior placoid retinitis, and this is one situation where multimodal imaging is a must for diagnosis. Many situations we do imaging more for documentation, but here it is absolutely necessary for diagnosis. I am showing you two retinitis lesions with their OCT, and both has full thickness retinitis, and we always have this confusion whether it is toxo or viral. In the first case, there is associated focal thickening of the choroid with hyporeflectivity and disruption of the choroidal architecture, adherent posterior hyaloid with dense vitritis, which definitely suggests this is toxoplasma. Whereas in the second case, the choroid is relatively spared because this is a retinitis and not a retinochoroiditis, and there is retinal tissue loss with hyperreflective vertical strips suggestive of cavernous retinitis, as we see in viral retinitis. There are some more differences. In the toxo, we see this characteristic round deposits along the posterior hyaloid, which is usually not seen in viral, and hyperreflective deposits on the inner retinal surface in toxo, whereas there is more chance for IRF and SRF in viral. See, these are not 100%, but these are points which will help us to make a differentiation. Now this is another elderly 48-year-old lady who came with decrease in vision. She's a diabetic, not well controlled, and it looked like something like a large cotton wool spot or retinitis-like lesions with hemorrhages and very significant macular edema bilaterally. So even DME was considered as a possibility. Another section we can see full thickness retinitis with inner retinal hyperreflectivity, pre-retinal and subretinal deposits. FFA showed blocked fluorescence corresponding to this lesion with hyperfluorescent margins. So then we had the doubt. So we asked for the history again. She had fever, but in dengue and leptospirosis was negative. Other uveitis workup also negative. So this is post-fever retinitis. And she responded well to treatment, but a repeat FFA showed inflammatory new vessels, which is very common in post-fever retinitis, so this is important. And she definitely improved with treatment, but somehow the vision in the right eye remained poor. And again, it is the imaging that helped us, which showed the significant cystoid edema with a VMT in the right eye. So imaging definitely has a role in during the entire follow-up of fever, post-fever retinitis. This is again another situation, an elderly patient with bilateral cataract, vitritis, and so the view is hazy, and again yellowish lesions which might make you think, is this a retinitis? But he is known case of CNS lymphoma, and the typical lumpy bumpy appearance with thick sheets of retinitis will definitely give us a diagnosis of primary vitreoretinal lymphoma. So again, to distinguish masquerades, imaging is so important. Now I'm showing you two images with multiple yellowish lesions, not as bright yellow as the retinitis we saw. Here you can see a huge choroidal granuloma with SRF, and here the lesion is more lobulated, ill-defined and non-homogeneous, and with the contact sign there is no doubt this is TB granuloma. Whereas in this case there are multiple small granulomas which are more rounded with well-defined margins and homogeneous, which tells you this is more likely a sarcoid granuloma. So again, in choroidal granulomas also the imaging will help us. Now this is a case of retinal vasculitis with hemorrhages, but it was FFA which documented not only the extent of inflammation but also helped us to identify the extent of non-perfusion and NVE, and she was then subsequently diagnosed as occlusive retinal vasculitis due to TB. This is another patient who's on ATT, and when he came to us, he had this extensive vasculitis with hemorrhages, and as expected, FFA showed the areas of capillary non-perfusion, and we did laser for him. I thought that should be fine. But during the follow-up, you can see there are many skip areas as well as new areas of capillary non-perfusion on the nasal side, which helped us to plan the supplemental laser. One more patient of TB retinal vasculitis had a yellowish lesion inferiorly which looked quite elevated, and we could really make it out only with the help of the OCT. And again, FFA showed the capillary non-perfusion, NVE, and the granuloma. So here we modified the treatment and gave an intravitreal anti-VEGF, and we can see the beautiful response post-injection. So extremely useful in retinal vasculitis, in the evaluation, in planning treatment, and in follow-up. Again, I am showing you two lesions, active lesions adjacent to a scar. In the first case, it is suggestive of reactivation of toxoplasmic retinochoroiditis, whereas in the second case, we can see subretinal hyperreflective material with intraretinal and subretinal fluid, and octa showing a network showing that this is a case of secondary CNV with toxoplasmosis. So it is only with MMI you can differentiate between reactivation and a complication. This is a 7-year-old boy who was diagnosed to have macular scar and was just left without any intervention, but they came to us for an opinion, and surprisingly it showed an active CNV which was confirmed on OCT and octa. We had to give injection under GA, and he beautifully responded. So in these kind of situations also, there is no substitute for imaging. This is another patient with ARN, which Dr. Neetu has already shown, treated with intravenous, intraoral, and antiviral and steroids. But then for aggressive management, we added intravitreal acyclovir also, and he responded very well. And we could really save him from the dreaded complication of retinal detachment. But 10 days later, he came back with complaints of decrease in vision, and you can see very extensive RP mottling, which we hardly see in a patient who resolved ARN. And this was highlighted much better in the autofluorescence. So then we had more doubt. OCT showed extensive hyper-reflective outer retinal deposits, extensive field loss on FFA. ERG showed gross reduction in the responses in the left eye, which I have shown in red boxes, compared to the right eye. MFERG also showed really reduced responses. So this was a case of retinal toxicity due to ganciclovir. And he is being followed up, and the lesions fortunately is improving. So in this kind of rare complications of treatment also, MMI has a valuable role. So advances in imaging has helped us to improve diagnosis and monitoring in infectious uveitis. Non-invasive modalities with high resolution images is helping us to see many details which we have never seen before. Each modality adds value in its unique way, so collective use is often needed, and judicious and cost-effective selection of the imaging modality is also important. Thank you, and I also acknowledge the help of my colleagues for the uveitis.